Okay. Bismillahirrahmanirrahim. So, yesterday we discussed strategies to treat peptic ulcer. So we started saying that if we have something that we need to deal with in terms of hyperacidity, we would start with giving an antacid. But in order for us to have a more protective strategy, we need to decrease the release of acid from the parietal cells through different mechanisms. And we mentioned that the parietal cells, they have different, on them we have different receptors that when bound to a ligand, in our case, gastrin, histamine, acetylcholine, they will lead to an activation of the hydrogen potassium ATPase, right? Which will ultimately release more acid. So if we block these pathways, of course, we basically mentioned two drugs in that regard, H2 blockers and antimuscarinic, pyrazine. And then we talked about inhibiting that main hydrogen potassium ATPase. Okay. Now, that's one part. So that's our second part. The third part is what? If I have an ulcer, exactly like I have a cut in the stomach, and we're gonna still eat, we're gonna still digest our food. So that ulcer, which is exposed to that harsh environment, we need to make sure that it is covered. So we need to add the third strategy of treating peptic ulcer, which is, in our case, we have to have a protective layer. So adding a protective layer. How we do that is we enhance the mucosal resistance of the gastric and intestinal wall towards HCl. Tamam? We will be talking about 3 examples: sucralfate, misoprostol, and Pepto-Bismuth. We call it Pepto-Bismuth, right? You've heard of Pepto-Bismuth? Bismuth salts. Okay. So, by the way, in these drugs, we need to make sure that we don't give them along the PPI. Yani we have to space them out. Why? Because they need that acidic environment to work, to function. Okay? So they form like a viscous layer. And that viscous layer is formed because there's an acidic environment. It's tailored in this way. Okay. Let's start with sucralfate. Sucralfate, sucra from sugar, and it's a sucrose. It's a sugar. So, sucralfate, it's salt of sucrose. It's complex to sulfated aluminum hydroxide, okay? Now what happens? In the stomach, it will be exposed to that acidic environment. That acidic environment will turn it into a viscous gel. Okay? Now, where does it like to bind? It binds to the injured part. And see how brilliant the idea is. It likes to bind to the already ulcerated area of the stomach. So the acidic pH leads to that complex salt, sugar salt, to dissociate into its components and polymerize to a viscous gel. Now, because there is a phosphate group in that sucralfate, it binds to a positive group, that is the protein molecules that are found in the damaged mucosa. Clear? Okay, there where it will, by the way, these drugs we have to make sure from drug-drug interaction because they might somehow inhibit some absorption. So they need to inform the doctor that I am taking these medications, okay? That's why we like to avoid taking H2 antagonist PPI because of that acidic environment that is well needed to activate these drugs. Second one, go ahead.
You mean like taking them at the
Uh-huh.
time?
Yes,
But in a more
we still take them. No, no.
More to regimen.
No. So you will see when we treat H. pylori, we call it quadruple regimen. It does contain bismuth, for example, and PPI, but the dosing should be spaced out. Okay. Second group of drugs, misoprostol. Have you heard of misoprostol?
Yes,
Sheikh.
it's a prostaglandin analog.
Okay, good. So why I'm using a prostaglandin analog?
Because it increases the concentration. When you want to give NSAIDs and you want for somebody who has ulcers.
Yes.
And,
Yes.
strong person.
So yes. So it has been thought that if I give, I know that the non-steroidal anti-inflammatory led that patient to get ulcer because we inhibited the production of prostaglandins. So what if I give him a prostaglandin A2? It's a specific prostaglandin that's there in the stomach. What does it do? So we said it's there's more than one point involved. Can you help me? So increase blood flow, increase the mucus production, carbonate, correct? Increase a little bit acid production. But in this case, we're interested in that mucus formation because we said it will form a protective layer. So misoprostol is one of the drugs that has been used for that reason. Okay, I just was carried away and moved to misoprostol before just reminding regarding the adverse effect. Sucralfate, patients can experience black stool, dry mouth, constipation. It's very safe because they're local drugs and doesn't get absorbed, so you can give it to a pregnant woman. Okay. Okay, and here we are. That's regarding the misoprostol. It's you just said it. What's the? Okay, so you just refreshed your colleague's memory in regards to the role of prostaglandin in general, that they provide a protective action in the stomach, increase release of mucosal carbonate, mucus, and inhibit peritoneal cell hydrochloric acid secretion. Okay, and go ahead.
For this drug, do we specifically give it to patients who are taking NSAIDs?
Yes, we do. But is it the first line? This is the thing, guys, that we understand mechanism of action in the lab, and then we introduce the drug in the market, and then they do clinical trials, and then they do post-marketing trials, and then the doctor starts prescribing these drugs, and what happens? Clinically, certain drugs are more popular than others. Provided we know the mechanism and provided we have all of this, there is something called in real life what's happening. So far, PPI is number one. Most of the regimens, that's what I said yesterday. I said all of the patients who are taking, who are being treated for peptic ulcer, part of the regimen is a PPI. Okay, so still they are second line, still, but they are still, we can use them. They are there in the market, but this is what we have. Okay, so and I said here, as you said, approved for prevention of non-steroidal anti-inflammatory drug-induced ulcer. Okay, clear? Okay. Now, do I have a contraindication with misoprostol? Okay. So for a pregnant woman, it's teratogenic, but is there like a?
If they have a hormonal imbalance, you can induce abortion.
Okay, so there's a secondary indication along with misoprostol is we can induce abortion, right? Okay. So, it is contraindicated for pregnant women. Go ahead. It increases uterine contractility. Yes. So misoprostol adverse effects, diarrhea and cramps. As we said, it can lead to abortion, and as your colleague said, it's teratogenic. Pepto-Bismuth, my favorite. Pepto-Bismuth is a product in the US. It's over the counter, and it's an absorbent. You know, it can also take care of patients who have diarrhea, right? But Pepto-Bismuth is a good agent, and it's been incorporated into the quadruple regimen for the treatment of H. pylori and treatment of peptic ulcer because of its protective factor, like sucralfate and misoprostol. It has a protective effect, but also, so it coats ulcer, stimulates mucus and carbonate secretion, which is very good. And it has a direct antimicrobial activity. So when you will see later on one of the slides, like a summary, you can look at it, you will see Pepto-Bismuth as a protective agent and as anti-H. pylori. Go ahead.
Last time we talked about H. pylori is a triple therapy.
Okay, but not only triple. Triple now, I'll talk about it. Okay. When was last time? I said triple therapy. Did I say triple therapy? I don't remember.
No, I think I say
Huh? Yeah, included triple therapy, quadruple therapy. Now it's like so many therapies. Okay, so also Pepto-Bismuth, don't worry if someone takes Pepto-Bismuth because it can lead to blackening of the stool and tongue. Okay, let's summarize a bit. It's a nice thick slide. I like to keep it. We inherited and I keep it from one year to the other because it has some sound system. Okay. Okay, so what do we have here? This is what? I've addressed, I've been looking at it. If you want to chat, you know what? I don't have any issue. No? بس كتير side chats بنتهاش. Okay, so what is this? This is a cartoon picture of what? So parietal cell. انتوا بتقولوا لها parietal انا بالparietal انتوا صح. Okay, so parietal cells. On the lumen side, we have the pump, the famous pump, right? But on the other side, we have several receptors, okay? So let's look at the CCK, which is a gastrin receptor expressed on the parietal cell. So we have the gastrin. If it gets bound to CCK, what do you expect the signal transduction pathway to be?
Yeah, it creates hydrogen pump outside.
Right, but in terms, how's that, through what route? IP3, so increase in calcium, this activates protein kinase, ultimately increase the expression of the pump. What I have looked at is that they increase the insertion of the pump at the membrane, okay? So, through several kinase activity. Then we have an H2 receptor expressed on the parietal cell. If histamine binds to it, which is a stronger signal, by the way. It's a stronger signal than both gastrin and acetylcholine. And we've mentioned this yesterday, and we looked at the diagram where the arrow is thicker for the histamine. And here we go. What happens? What's the signal? What should happen? Activation of what? So activation of adenylyl cyclase, ATP to adenylyl cyclase to cyclic AMP, and activation of protein kinase, and we have activation of the pump again. So release of gastric acid. I think it is. It can be both, but what I saw is more likely is it is like we have the pump in the cytoplasm, and we are enhancing it to be expressed to the or insertion in the nerve. Okay. Now, third one is a prostaglandin E receptor. Now what happens?
Inhibited.
Okay, let's see. Oh, did I miss something? Okay, prostaglandin E2, it binds. Now what happens? So nothing happens, which means no activity of the allele cyclase. The fourth one is let's say paranzepine, right? Or let's say acetylcholine binds to the M3 receptor. Also, it activates IP3, elevation of calcium ions, activation of protein kinase, and we have the pump activated. Okay, clear? Now, if I want to decrease the gastric acid, what happens? I will give whatever is there in terms of acidity. I will give an antacid to what is, if we have hyperacidity, we can't do anything. If I have hyperacidity, already the parietal cells has released a lot of acid. I can't give PPI to help my pain. Correct? I should take an antacid right away because it will neutralize whatever acid is available in the stomach. Okay. Alternatively, I would give, for example, nizatidine to inhibit H2, and this will take care of decreasing the release. And I would give omeprazole to inhibit, which is a covalent bond. Remember, it binds covalently, and this is more effective. And also misoprostol. If I give misoprostol, this also can be another way of looking at treating my ulcer, and that's it. Okay. Now the fourth regimen. So let's revise them. We did 3 regimens. This is the fourth one. What's the first one? Okay. Second one, decreased production. Okay. Third one, a protective layer, forming a protective layer. And fourth one is just that bacteria. And by the way, I am mistaken. He is Australian, that guy who discovered that. I will apologize to the guy at one. And how did this whole thing start? So this whole thing started by having this stigma, or have not stigma actually, I'm sorry, but it started with the idea that stress leads to ulcer. That's it. If you're stressed, you will have ulcer. And that guy was not convinced. No one would help him, no one would talk to him until he decided, okay, you know what, I'll try it myself. Okay, so is Dr. Barry Marshall. He was convinced that this is it's a bacteria that causes this whole thing, and he decided to have it and treat himself with an antibiotic because the theory that gastric ulcer was mostly a psychosomatic affliction caused by too much stress. Okay. Right. Triple therapy. Let's talk about H. pylori. We're talking about ulcer and the main causes of ulcer. There are only 2 non-steroidal H. pylori. What does H. pylori? Yes. Okay. First of all, you know the hot and cold season. H. pylori, the acid and the environment of the 4th season of H. They're in La La Land, they have fun, no problem. How are they surviving in this harsh environment? They are dividing in the mucus. Okay? Now what? So they are living in their own bubble.
So they break down the acid.
So they have this enzyme called urease, which takes down the urea into ammonia, which is very alkaline. So I'm happy. Now let's start working. Let's intake the stomach and let's form the ulcer, and they're happy and surviving very well. Okay, so triple therapy, they started with giving 3 types. PPI is one of them, and then clarithromycin, which is a macrolide, along with amoxicillin if we are not allergic to penicillins, or metronidazole. Okay, so this is called a triple therapy. Okay, where is the problem? طبعا the duration 7 to 14. 7 to 14. هلا. They found that giving PPI can have a synergistic effect with the antibiotics to eradicate H. pylori. Excellent. Okay. Now, where is the issue? Where do you think the problem is?
Resistance, the antibiotic.
Very good. Now, they have thought that clarithromycin, if the local society has more than 15% resistance, then we should replace the clarithromycin. Now, there is some point mutation that they can be seen in the H. pylori that will create that resistance. How? Different routes. How they activate an efflux pump. So the H. pylori, once clarithro gets in, you're out. Okay? Or it breaks down the macrolide ring. Okay? I forgot. What is
Binding side.
Huh? Huh? What is it?
You said binding side.
Or it could be, but I'm not sure. So let me recall it. Give me 1 minute. Okay. So this mutation, this point mutation, I mean, now when they do the certain studies, they go genetically and they screen the patients, the H. pylori, they screen for the point mutation, and then they know these are resistant to clarithromycin, and they start giving alternative therapies. And we don't do it often. We see that if someone, if it did not work, then just it's by default we have resistance to clarithromycin, then we move to our quadruple therapy, our other therapies. But now, what they have tried to do here, one of the regimens that I have seen is they will increase the proton pump dose and they will elongate it for 14 days, not 7 days. Okay. So in areas where the prevalence of resistance to clarithromycin is high, we need to move to quadruple therapy. Quadruple, 4. Okay? In patients with recent, who would be given quadruple? Oh, I have been taking Clarithro recently. So, and then I discovered I have cardiac ulcer. Clarithro should not be my option. Out the area there's a prevalence of resistance, so I wouldn't risk it from the beginning and not give. Or I've started triple therapy, it failed. So I moved to quadruple therapy. Okay? So the quadruple therapy is where they added the bismuth. Okay, so PPI is there. Bismuth is added, a metronidazole and the tetracycline. And they give it for 14 days. Okay? Sometimes they would give quadruple would be PPI, clarithromycin, amoxicillin, and a derivative of metronidazole, nitramidazole, again for 14 days. And this is a quadruple therapy. I think with this we are done for today's lecture. I just don't want you to freak out when you see number of drugs. Whatever drugs I've mentioned in the previous slide, these are your responsibility. Anything else, I just took an image for you just to revise when you go back home. If you see a drug that I haven't mentioned in the previous slides, please go ahead and ignore, okay? Just not to overwhelm yourself, okay? And I think in summary, this is a good summary for you to look at all the pathways and all the receptors and what is responsible for what. Okay? يعطيكم العافية. In the quadruple, yes, we give metronidazole and we give bismuth, PPI, and we give